Hello, everyone, and welcome. Thank you for joining us this afternoon. My name is Lucia Posel, and I am the research assistant for the Best Practices Core here at the University of Vermont Center on Rural Addiction. Thank you for joining us today. The Community Rounds Workshop Series is a live webinar series provided monthly by the University of Vermont Center on Rural Addiction to provide opportunities for healthcare professionals to learn, ask questions, and discuss topics related to science-based best practices for substance use disorders. These sessions usually include about 45 minutes of presentation, followed by 15 minutes for questions and conversation. Before we begin today's session and I introduce our speakers, I'd like to go over a couple of reminders. First off, we encourage you all to ask questions and engage with our speaker today. But we do ask that you please save your questions for the time reserved at the end, or you can feel free to enter them in the chat box during the session and we will make sure to address them during our Q&A period. If we do run out of time for your question, we'll be sure to follow up with you via email. Mics and videos for participants will be turned off. We ask that you keep them off for the duration of the session, but encourage you to turn them on when we get to the end and Q&A so we can see everybody's face as we discuss Dr. Peck's presentation. We also recommend that you change your viewing settings to speaker view on Zoom so you can focus on Dr. Peck during his presentation. For folks who are joining us by phone, you all should be muted. You can mute and unmute yourself by pressing *6. And as a reminder, this presentation is being recorded and a copy of the slides and recording will be shared later in the week following this presentation. And we're really excited to offer CME and CE credits for this session today. We will share the link for instructions on how to claim these credits during the session. If you have any questions, you can contact us directly at cora@uvm.edu. We do ask that you claim these credits within 30 days of the live webinar. And just as a formality, we have to go over disclosures. There is nothing to disclose for this community round session, and all potential conflicts of interest have been resolved prior to the session. And we can go ahead and I'm going to introduce Dr. Stacy Sigman. We are happy to have her with us this afternoon. Dr. Sigman is the PI for our HRSA grant for the UVM Center on Rural Addiction. She is also a tenured associate professor of psychiatry at UVM and researcher with the Vermont Center on Behavior and Health at the Larner College of Medicine. She holds many roles here with us, and we're really happy for her to join us this afternoon. And she is here to introduce our speaker. So Dr. Sigman, I'll hand it over to you.
Well, happy New Year, everyone, and so glad that you could join us for today's community rounds. It's really my pleasure to introduce my colleague and collaborator, Dr. Kelly Peck, for today's session. Kelly is a clinical psychologist, and he's been here with us at UVM since, I think, 2017, right, Kelly? Mm-hmm. He completed his graduate training in clinical psychology at the University of Mississippi and has really extensive expertise working with and treating patients with concurrent substance use disorders and mental health issues. Kelly's most recent work has been focusing especially on conducting rigorous randomized clinical trials evaluating novel buprenorphine treatment approaches for patients with opiate use disorder, and more recently developing and evaluating an evidence-based treatment that's customized for reducing PTSD symptom severity in opiate-dependent patients. And so in our community round session today, Kelly's going to be telling us about one of the most empirically supported and effective approaches for addressing PTSD-related distress in patients, as well as some of the common challenges that we often face when we're treating PTSD among patients with concurrent opiate use disorder and other forms of substance use disorders. So welcome, Kelly. I'll hand it over to you, and thanks again for sharing your work with us today.
Thanks for the introduction, and thanks for having me. So as Dr. Sigmund mentioned, my name is Kelly Peck, and I am an assistant professor here at the University of Vermont in the Vermont Center on Behavior and Health. And so today I'll be presenting on co-occurring post-traumatic stress disorder and substance use. And specifically, I'll be focusing on the epidemiology, assessment, and treatment of these co-occurring disorders. So just as an overview of this presentation, I think this presentation will be a little bit different from a lot of the presentations that I do over the course of the year, and that I won't be exclusively focused on research that I'm currently conducting. Instead, I've been trained as a clinical psychologist. And so this presentation, what I hope to do is to approach concurrent PTSD and substance use through a clinical lens with the goal of providing treatment providers in Northern New England with information or resources that could be helpful in providing evidence-based trauma assessment and treatment to patients who are enrolled in substance use treatment. And so I'll start off today by providing a definition of trauma in post-traumatic stress disorder according to the DSM-5. I'll then present an overview of PTSD prevalence, both in the general population as well as among individuals with substance use disorder. I'll review some helpful assessment tools and strategies, as well as some effective treatment approaches for PTSD. And then towards the end, I'll discuss some specific considerations for working with rural populations, as well as individuals with concurrent PTSD and substance use disorder. So to start off, just providing some definitions. So according to, well, first off, PTSD, or post-traumatic stress disorder, is defined as a psychiatric disorder that occurs in people who've experienced or witnessed a traumatic event. So the first step in understanding PTSD is understanding how the DSM defines a traumatic event. So according to the DSM-5, a traumatic event is being exposed to actual or the threat of death, serious injury, or sexual violation. And so trauma can either occur by experiencing the event yourself, witnessing it occur to someone else, or learning that the event occurred to a close relative or a close friend. And in such cases where an individual learns about a traumatic event, the actual or threatened death has to have been violent or accidental. Another way that trauma exposure can occur is through experiencing repeated or extreme exposure to aversive details of an event, often through part of job responsibility. So I think about first responders, potentially collecting body parts, or police officers who are repeatedly exposed to the details of child abuse. So this is how the DSM defines trauma. Trauma is one of those words that's frequently used, but when we talk about trauma from the DSM perspective, this is what we're talking about. And so in addition to trauma exposure, the presence of PTSD is marked by the presence of symptoms from 4 different symptom clusters. And as I go through these symptom clusters, you'll notice that as I go through each, I've specified the total number of symptoms that are required for diagnosis of PTSD. So this first symptom cluster is intrusion symptoms. And so to receive a diagnosis of PTSD, an individual would need to report at least one of these symptoms. And these symptoms include thinking about the trauma when they don't want to, distressing dreams and nightmares. These dissociative reactions that are sometimes referred to as flashbacks, which are characteristically different from memories or dreams. And this occurs when somebody is awake, but they actually may lose track of where they are, may lose track of time. It's a dissociative experience. And then we also frequently see intense and prolonged psychological or physiological reactions in response to cues that remind the individual of their traumatic event. So those psychological cues can be fear or horror, whereas the physiological reactions can be an increased heart rate, sweating, hyperventilation, and things of that nature. The second symptom cluster is avoidance, and avoidance is really a core symptom of PTSD that helps differentiate PTSD from other disorders. And so avoidance would be either avoidance of internal reminders or external reminders that arouse recollections of the traumatic event. So the individual might report avoiding thoughts, feelings, physical sensations that remind them of their traumatic experience, or they may avoid things out in their environment, like people, places, or situations. The next symptom cluster is cognitive and mood symptoms. And so an individual would need to report at least 2 symptoms from this symptom cluster to receive a diagnosis of PTSD. And so these symptoms include an inability to remember important aspects of the event, persistent or exaggerated negative beliefs about oneself, people, or the world, blaming oneself for the event, pervasive negative emotions like fear, horror, guilt, and shame, diminished interest or participation in activities that they used to find enjoyable, or feelings of detachment or estrangement from other people. And then oftentimes people report an inability to experience positive emotions. So they might report having difficulty feeling love or happiness. And then the final symptom cluster is arousal and reactivity symptoms. And this would include irritable or aggressive behavior, reckless or self-destructive behavior, hypervigilance, an exaggerated startle response, problems with concentration, or sleep disturbances. And then, so in assigning a diagnosis of PTSD, we would also want to determine how long these symptoms have been present. And so to meet criteria for PTSD, these symptoms would need to be present for at least 1 month. And this allows us to differentiate PTSD from a more acute stress response. Oftentimes following a traumatic experience, people do experience these symptoms that I just described. But when these symptoms persist for at least a month, that's when we start to talk about PTSD versus an acute stress response. We would also need to assess whether or not these symptoms are causing significant distress or impairment in this individual's ability to function. And we would specify whether there was delayed onset. So in some instances, people don't experience symptoms of PTSD until sometime after the traumatic event. This is particularly true of combat trauma. And then we would also specify whether the person is experiencing need dissociation or depersonalization. And so as I've gone through these 20 symptoms of PTSD, you can see that there are different symptom clusters. And then within each cluster, there are multiple symptoms. And so as you can tell, or maybe you can tell as I've gone through these symptoms, there can be a great deal of heterogeneity in the symptom profile. And indeed, a recent article came out this year, and it documented that there are 636,120 possible combinations of symptoms that would meet criteria for DSM-5. And so given the way that DSM-5 defines PTSD, it can make assessment challenging in that one person with PTSD can look really different from another depending on the symptoms that they're reporting. So now that we've defined trauma and we've defined PTSD, I want to spend some time just talking about the prevalence of trauma and PTSD within the general population. So on this slide, the orange bars indicate men and those yellow bars indicate women. On the left, in the leftmost graphic, you can see that 61% of men and 51% of women in the general population report experiencing trauma during their lifetime. And then as your eyes move there to the right, in terms of the number of traumas, 27% of men and 26% of women report experiencing one traumatic event during their lifetime, whereas 34% of men and 25% of women report experiencing multiple traumas during their lifetime. So the main takeaways here is that trauma is not an unusual experience. Many people report trauma over the course of their lifetime, and men are more likely to report trauma relative to women. In this next slide, this is looking at lifetime prevalence of trauma and PTSD. Again, those orange bars, I just presented this data on the previous slide. So 61% of men and 51% of women report trauma during their lifetime. The yellow bars indicate the percentage of those individuals who go on to develop symptoms of PTSD. And then the green bar indicates the percentage of these individuals who experience trauma who recover naturally, who never go on to develop PTSD. And so the interesting thing here is that many people who experience trauma during their lifetime don't develop PTSD, they recover naturally. And another interesting thing that you can take away from this slide is that even though men are more likely to experience trauma, women are more likely to then go on and develop PTSD. So now that we've talked about the prevalence, let's talk about the cost and burden of PTSD. Why is this disorder important? So individuals with PTSD are significantly more likely than individuals without PTSD to develop neurological, vascular, respiratory, gastrointestinal, metabolic, autoimmune, and musculoskeletal disorders within the past year. So PTSD is associated with a host of negative of medical consequences. PTSD also frequently co-occurs with other psychiatric conditions. So of individuals with current PTSD as their primary diagnosis, 92% of these folks were also diagnosed with a concurrent anxiety or mood disorder. So major depressive disorder, panic disorder, obsessive compulsive disorder were some of the most prevalent co-occurring psychiatric conditions. And over a third of individuals with PTSD meet lifetime criteria for alcohol or drug use disorders. And so even though substance use is not a symptom of PTSD, substance use problems and PTSD frequently co-occur. We also see that PTSD is associated with suicidality. This is a relatively small sample examined in this study by Amaya Jackson in 1999. But compared to controls who didn't have PTSD, individuals with PTSD were significantly more likely to report suicidal thoughts and attempts during the past year. So we know that PTSD, that trauma is prevalent, that individuals who go on to develop PTSD experience a host of negative consequences. And so now I want to shift to looking at the prevalence and burden of PTSD in individuals with substance use disorders. So as I just talked about, approximately 40% of individuals with substance use disorders also meet criteria for PTSD. And given that we're in the midst of an ongoing opioid epidemic, and most of the work that I do focuses on novel treatments for opioid use disorder, this co-occurrence may be particularly relevant to individuals with opioid use disorder. Particularly as I think about the increasing rates of opioid overdose that we've seen over the past couple of years. If you think about an overdose, whether it happens to you, whether you witness it happen to someone else, or maybe you learn about a friend who's died from an overdose, that's a traumatic event. And so individuals who are using illicit opioids are at high risk for trauma exposure. And what we know is that almost all individuals with opioid use disorder report lifetime trauma, about 90%. 1/3 of these individuals go on to meet criteria for PTSD. And so if you look at this table, you can see comparing rates of trauma exposure and PTSD in individuals with opioid use disorder to the general population. The rates of trauma exposure and PTSD in individuals with opioid use disorder is far in excess of what we see in the general population. I wanted to provide a snapshot of what's happening in our own community. So this data, we pulled this data from the Chittenden Clinic here in Burlington, Vermont. The Chittenden Clinic is the largest opioid treatment provider in the state of Vermont. And this is just kind of a quick and dirty assessment that patients fill out at intake that assesses symptoms of PTSD. And so what we found is that 94% of Chittenden Clinic patients endorse at least one PTSD symptom. So that's not to say that 94% of these patients meet criteria for PTSD, but the vast majority are experiencing some trauma symptoms. And the statistic that really stands out to me is that 61% of these individuals reported experiencing or witnessing a traumatic event within the past month. And so just to put that into context, the past month trauma exposure for these individuals is equivalent to the lifetime trauma exposure within the general population. So this is a high-risk group. We've talked about all the negative consequences associated with PTSD. When substance use disorder and PTSD co-occur, substance use treatment outcomes can also be negatively impacted, particularly, if you think about those with co-occurring PTSD compared to individuals with substance use disorder alone. Those with concurrent PTSD and substance use disorder report more intense substance cravings. They're more likely to drop out of treatment, and they also report more frequent and quicker relapse to substance use. So this is a population that I think is certainly deserving of attention. And so I've presented some epidemiological data and just outlining what the problem is. I want to shift here and start providing a little bit of information that I think is relevant clinically, and that is So if we are working in substance use treatment settings, how do we go about assessing and then providing treatment to individuals who are struggling with trauma and PTSD symptoms? And so I'll start off just by talking a little bit about assessment. So in order to effectively determine the course of treatment for an individual with concurrent PTSD and substance use disorder, the first step is, it's important to first conduct a thorough evaluation of both trauma and PTSD. The first step would be determining whether or not an individual has experienced a traumatic event. And if they've experienced multiple traumas, which is frequently the case, we want to identify the index trauma. And when I talk about an index trauma, what that means is the index trauma is a traumatic event that bothers the patient the most right now. What is the event that really has caused you the most problems currently? After we've determined whether or not somebody has experienced trauma and whether index trauma is, we would then need to assess for symptoms, symptom severity, and a diagnosis of PTSD, because remember, not everyone who has experienced a trauma goes on to develop PTSD. And it would also be important to assess for other comorbid psychiatric conditions and substance use disorders that could potentially account for these symptoms or interfere with treatment. And so this is accomplished with both the use of both interview and self-report measures. And so on this slide, what I've attempted to do is to list some measures that I have found both in clinical practice as well as in research to be helpful and probably the best measures that are out there. So there are many different measures that you can use to assess for symptoms of PTSD. And just because a measure isn't listed on this slide doesn't mean that it's not a perfectly reasonable measure to use. But what I've tried to do here is to prioritize valid and reliable measures that are free and publicly available. So what I'll do now is I'll just kind of walk through what a PTSD assessment would look like, talk about a couple of measures that I use, and just kind of outlining what a comprehensive assessment of trauma exposure and PTSD would look like. So one measure that I think is really great for implementation in clinical practice is the life events checklist for DSM-5. So this measure assesses for exposure to 16 events that may potentially result in PTSD or trauma-related distress. It also includes one item that is kind of a catch-all for any other extraordinarily stressful event that isn't measured in the first 16 items. So this is a good measure to determine, has an individual been exposed to trauma? If they're endorsing trauma during their lifetime, the next step would be then to screen for the severity of PTSD symptoms. And one really great measure that's easy to implement in clinical practice is the PTSD checklist for DSM-5. It's a 20-item self-report measure that assesses the presence and severity of PTSD symptoms. Most people can complete this measure in 5-10 minutes. It assesses all 20 symptoms of PTSD that I outlined at the beginning of the presentation. So if an individual would rate each symptom on a Likert type scale from 0 to 4 in terms of how much that symptom has bothered them. In the research study that I'm currently conducting, we assessed over the past month. But there are multiple versions of the PCL that vary slightly in instructions and the wording referring to the index event. And so the individual would rate all 20 symptoms on a scale from 0 to 4, and you would get a total severity score that ranges from 0 to 80. Depending on the research that you look at, a cutoff score for a probable diagnosis of PTSD ranges between 31 and 33. And so this measure really functions as a screener. And if somebody were to score 33 or above on the PCL, you could pretty reasonably conclude that this person is, I would not assign a diagnosis based on this measure, but you could assume that this person is struggling with symptoms of PTSD or trauma. And then the next step would be to conduct a more thorough clinical interview. The measure that I use most frequently is the Clinician Administered PTSD scale for DSM-5. This is really the gold standard in PTSD assessment that was developed through the VA. It's a 30-item structured clinical interview that allows a clinician to make a diagnosis of PTSD and then to obtain an estimate of the severity of symptoms. This is a bit more involved compared to some of these self-report measures that I've already discussed. And that the interview should probably have some training in differential diagnosis and being able to differentiate between, are these symptoms that the person is reporting, are they attributable to PTSD, or they may be attributable to another psychiatric disorder like anxiety or generalized anxiety disorder, or maybe major depression. The assessor should also have a good understanding of PTSD symptoms and familiarity with the CAPS-5 manual on administration. Probably some training would be helpful. In administering this measure, you would first identify the index trauma. So what is the event that's bothering you the most? That would serve as the basis of symptom inquiry. And there are 3 versions of the CAPS-5 that correspond to past week symptom severity, past month, and then worst month over the course of a lifetime. And just to provide an example here, for each symptom, there are standardized questions and probes that are provided to achieve the most reliable and valid results. It's very protocolized and scripted. And the assessor would combine information about the frequency and the intensity of an item into a single severity rating. So I pulled this from the CAPS. The assessor would rate the intensity of the symptoms from minimal to extreme. They would gather information about how frequently that symptom has occurred during the past month. And then they would kind of consolidate, they would consider that information together to assign a severity score that ranged from 0 to 4, from absent to extreme. The CAPS-5 provides a total symptom severity score for the 20 PTSD symptoms. The scores range from 0 to 80. And you can also use this measure to determine whether an individual meets DSM diagnostic criteria for PTSD. So these are just some helpful measures that I think that can be easily implemented, or relatively easily implemented, into clinical practice to assess for trauma and PTSD. I've listed here some other useful assessments. As I mentioned, a major part of assessing for PTSD is being able to differentiate symptoms of PTSD from other disorders. So I've listed here some readily available measures that would assess other psychiatric disorders, recent substance use, measures of functioning, as well as self-report measures of depression and anxiety. And so these are some useful measures that we frequently use in both clinical and research practice that would also be helpful to implement. So I wanted to provide those to anyone who's interested. And so now that we've talked a bit about assessment, I'll spend the next couple of minutes talking about effective treatment for PTSD. There are a number of PTSD treatments that are available that range from individual counseling to group therapy. Eye movement desensitization and reprocessing is a really hot topic within the trauma and PTSD world currently. But for the sake of this presentation, I'm really going to focus on short-term cognitive behavioral therapy, as this is the one type of therapy that has been systematically studied and therefore is evidence-based. And these interventions are typically very effective in a relatively short period of time, 8 to 15 sessions on average. Regardless of, if we're talking about cognitive behavioral treatments, or CBT, regardless of the intervention that we're talking about, the general goals are to promote safe confrontations with trauma reminders. So those confrontations could be through real life exposure or via discussion. And those trauma reminders could be internal, like memories, or they could be external reminders, people, places, and situations. And the goal of CBT typically is to modify the dysfunctional cognition that underlie PTSD. The 3, if we really categorize these evidence-based treatments, the 3 categories that I think about are anxiety management procedures, cognitive therapy, and then exposure procedures. If we're talking about anxiety management treatment, this would be the same thing as stress inoculation training. It consists of relaxation training, controlled breathing, positive self-talk and imagery, social skills training, as well as some distraction techniques like thought stopping. And the basic idea with this intervention is to develop skills to help reduce the physical and psychological arousal associated with PTSD. When we talk about cognitive therapy, this is, in the tradition of Aaron Beck and others, the idea is to identify dysfunctional, erroneous thoughts and beliefs or cognitions, to challenge those cognitions, and then to replace those cognitions with functional and realistic cognitions. And so probably the most identifiable brand of cognitive therapy for PTSD is cognitive processing therapy. And in cognitive processing therapy, cognitive restructuring focuses on issues of safety, trust, power, esteem, intimacy, as these beliefs or these cognitions are often negatively impacted in individuals with PTSD. And in cognitive processing therapy, the individual would engage in a repeated writing of the traumatic experience, and treatment typically consists of 12 weekly sessions. And then the third evidence-based treatment for PTSD is exposure. So prolonged exposure therapy, this really stems from the work of Edna Foa and her group at the University of Pennsylvania as they protocolized an exposure, prolonged exposure therapy for PTSD. Prolonged exposure therapy really consists of two components. The first is imaginal exposure. So that is repeated revisiting, recounting, and processing of the traumatic event in session with the therapist. And this imaginal encounter, or that retelling of the trauma narrative, enhances the processing of the traumatic memories and helps the person attain a more realistic perspective on the trauma. And then outside, the second component of prolonged exposure therapy is in vivo or real life exposure. And that is repeated confrontations with situations, activities, places, maybe even people that are avoided because they're trauma reminders. We would do this in totally safe situations. We're not exposing people to real danger. But the idea is that these encounters or these exposures reduce trauma-related distress, and they enable the patient to realize that the avoided situations are not dangerous and that they're able to cope with the distress. And so on average, treatment consists of an average of 8 to 15 90-minute sessions. And so these are kind of the three evidence-based treatments for PTSD. I want to take a little bit of time to talk about the empirical evidence for prolonged exposure therapy, as well as some other treatments for PTSD. So this first study comes from Edna Foa and her group. I mentioned her from the University of Pennsylvania. This study was conducted in 1999. And in this study, 96 female sexual assault victims were randomized to one of 4 treatment groups. They received either prolonged exposure therapy, stress inoculation training, or a combination of those two interventions, or they were randomized to waitlist. And treatments included 9 sessions that were conducted over 5 weeks. And so you can see in this figure, this is the results, the main findings of that study. On our x-axis, you can see each of the treatment groups. On the y-axis, you can see PTSD symptom severity, and I've included a line to mark a clinical cutoff for PTSD. And so what you can see from this study is that all 3 active treatments reduced the severity of PTSD symptoms compared to waitlist. The 3 active treatments did not differ significantly from each other in those gains. So you can see that that green bar indicates a 12-month follow-up. So 12 months following the beginning of treatment, those gains were maintained at that follow-up treatment for all 3 treatment groups. Study 2, this is again Edna Foa's group from 2005. And in this study, 171 female assault victims were randomized to one of 3 treatment conditions. And in this study, individuals were randomized either to receive prolonged exposure therapy plus cognitive restructuring, or waitlist. And so treatments included 9 weekly sessions. And for individuals who are identified as partial responders, or those who hadn't achieved a 70% reduction in their symptoms by week 9, those individuals were extended 3 additional sessions. And so in this study, here are the results. Again, you can see treatment group on the x-axis. You can see the PTSD symptom severity on the y-axis, and the different colored bars indicate pre, post, and 3-month assessment time points. And in this study, both treatments reduced PTSD symptoms compared to the waitlist condition, and those treatment gains were maintained at 3-month follow-up. So that there are a couple of interesting takeaways from this study. The first being that the addition of cognitive restructuring didn't enhance treatment outcome. Prolonged exposure therapy in and of itself seemed to be sufficient in reducing PTSD symptoms. An interesting secondary finding of this study was that treatment in the hands of counselors who had minimal cognitive behavioral therapy experience was just as efficacious as therapy administered by those who were identified as CBT experts. So I think that this point is particularly relevant in substance use treatment settings, in that prolonged exposure therapy is a great candidate for dissemination, and that you can train clinicians to deliver prolonged exposure therapy effectively even if they don't have a ton of experience treating PTSD or even using protocolized interventions. This study is a little bit more recent. This study comes from Rizik et al. In 2002, and then they did a long-term follow-up in 2012. And in this study, I believe, I can't remember the exact number of participants, but several hundred were randomized to one of three conditions. They were randomized to either receive cognitive processing therapy, prolonged exposure therapy, or a minimal attention condition. And so as you can see, again, we've got on this slide, it changes a bit. We've got our assessment time points on the x-axis, PTSD symptom severity on the y-axis, and the different colored bars represent the different types, the randomization or the treatment groups. And so you can see that both cognitive processing therapy and prolonged exposure therapy were efficacious in reducing PTSD symptom severity, and both were superior to the minimal attention condition. Those decreases in PTSD symptoms were maintained throughout the long-term follow-up period. So they they published a paper in 2012 showing these long-term outcomes between 5 and 10 years following treatment, and that these treatment reductions were sustained over a long period of time. There were no significant differences between the two treatment groups at any time point. And so this is a good study to indicate that cognitive processing therapy or prolonged exposure therapy appear to be effective treatments for PTSD. One note, one of the secondary findings of the study was that there was a trend that those who received prolonged exposure therapy tended to have less relapse at that long-term follow-up point compared to those who received cognitive processing therapy. And then finally, I'll just touch on this really quickly because, as I mentioned, eye movement desensitization and reprocessing seems to be a hot topic within the trauma world currently. In this study, this is from Taylor et al. In 2003, 60 participants were randomized to one of three treatments for PTSD. They received either prolonged exposure therapy, relaxation training, or eye movement desensitization and reprocessing, so that's EMDR. And compared to EMDR and relaxation training, prolonged exposure therapy was associated with larger reductions in PTSD symptoms and yielded a greater proportion of participants who no longer met criteria for PTSD following treatment. So the EMDR and relaxation groups did not differ from one another in terms of efficacy. And so this study seems to suggest that prolonged exposure therapy is more efficacious than EMDR or relaxation in reducing symptoms of PTSD. So although there are multiple treatment modalities that are effective for the treatment of PTSD, there are a number of advantages that are associated with prolonged exposure. This is the type of work that I do. We're currently engaged in a study looking at prolonged exposure therapy in individuals with concurrent opioid use disorder. And so prolonged exposure therapy has the largest number of studies supporting its efficacy and effectiveness. It's been found effective in the widest range of trauma populations. And it's also been studied by many independent research groups in the United States and around the world. It's a good candidate for dissemination, as I mentioned, in that it is effective in the hands of non-experts, and this has been documented in several studies. So I've talked about several treatments that are efficacious for the treatment of PTSD. I want to focus specifically for a couple of minutes of what this looks like in treating PTSD in individuals with concurrent substance use disorders. So many individuals with substance use disorders, even though we have evidence-based treatments for trauma, many folks with substance use disorders have not received treatment for their co-occurring PTSD symptoms. And this is based on this long-held notion that substance use will interfere with an individual's ability to benefit from PTSD treatment, as well as concerns that PTSD treatment will somehow exacerbate psychiatric symptoms and prompt substance use relapse or treatment dropout. The good news is that over the past decade, there are a growing number of studies that are pretty consistent in suggesting that prolonged exposure therapy specifically can be delivered to improve PTSD symptoms without exacerbating substance use among patients with substance use disorders when prolonged exposure therapy and evidence-based substance use treatment are delivered concurrently. So one study that I wanted to highlight, this again is from Edna Foa's group at the University of Pennsylvania, and this study was conducted in 2013. And in this study, 165 participants with alcohol use disorder were randomly assigned to one of four groups. In the first group, Participants received prolonged exposure therapy plus naltrexone, which is an evidence-based treatment for alcohol use disorder. In the second group, they received prolonged exposure therapy plus a pill placebo. The third group received supportive counseling plus naltrexone. And then the fourth group received supportive counseling plus pill placebo. In this study, if you look, they looked at several different outcomes, the first being the percentage of days drinking. And so in this study, participants in all four groups showed a large reduction in the percentage of their days drinking. Those who received naltrexone had lower percentage of days drinking than those who received placebo. And then 6 months after the end of treatment, participants in all four groups had increases in the percentages of days drinking. So there you saw the effect of the intervention wear off, as you often do over that prolonged follow-up period. However, those in the prolonged exposure therapy group who also received naltrexone had the smallest increases in their drinking at that long-term follow-up. In terms of PTSD treatment outcomes, you see, as you can see with this graph here, we've got time on the x-axis, PTSD symptom severity on the y-axis, and then the different treatment groups are indicated here. There's a reduction in PTSD symptoms for all four groups, and the main effect of prolonged exposure therapy was not statistically significant. These findings are pretty interesting in that they are inconsistent with a large body of evidence that indicates that prolonged exposure therapy is an effective PTSD treatment. And so these results may be attributed to the fact that everybody in the study also received supportive counseling, which may have masked some of the unique effects of prolonged exposure therapy. And attendance rates in this study were also lower relative to previous studies of prolonged exposure therapy. This study I'm particularly fond of. This study was conducted by Scott Coffey et al. In 2016. This is the group that I trained in as part of my graduate training at the University of Mississippi Medical Center. And in this study, you know, this is, you can kind of see this as an extension of the work that NFO and her group have done. In this study, 126 individuals who were receiving 6 weeks of residential substance use treatment were randomized to one of 3 PTSD treatment groups. Individuals were randomized to either receive prolonged exposure therapy plus trauma-focused motivational enhancement therapy, or they were randomized to a healthy lifestyles control group. And in this control group, participants received 9 to 12 sessions of education that focused on a variety of health-related topics. And so the idea here was to provide all 3 of these groups. The idea was that they would receive an equivalent amount of clinical attention. And then all participants in the study also received treatment as usual for substance use. And this was in this treatment center, that model was based on the AA model and consisted of both group therapy and individual drug counseling. So the groups were balanced in terms of clinical attention, and the difference between groups really focused on the type of trauma treatment that they were receiving. And the results of the study indicated that both of those prolonged exposure therapy groups achieved significantly better PTSD symptom outcomes than the control condition. The 2 prolonged exposure therapy groups did not differ from one another, so that motivational enhancement component didn't seem to have much of an effect. So the prolonged exposure therapy was associated with a reduction in PTSD symptoms at the end of treatment, 3 months and 6 months, compared to that healthy lifestyles group. Substance use outcomes did not differ between groups, with all groups achieving between 86 and 98% days abstinent at follow-up. And it's worth noting here that even in this residential setting, only 60% of participants completed treatment. And so as you can see, with prolonged exposure therapy, like any behavioral intervention, attendance can be an issue that may affect outcomes. And if an individual isn't receiving a full dose of the treatment, they might not be receiving the maximal benefits from the intervention. So quickly, I'll talk about some research that I'm involved in. Even though we know that it appears that prolonged exposure therapy is efficacious among individuals with substance use disorder, we know less about the effects of prolonged exposure therapy among individuals with opioid use disorder. There are 3 recent studies, including one that I published in 2018, that indicate that prolonged exposure therapy is associated with reductions in PTSD symptoms among patients who are receiving concurrent treatment for opioid use disorder. In all of these studies, attendance is frequently a barrier, as I noted, and none of these studies included a control condition in which participants received opioid agonist therapy without PTSD-focused therapy. And so as a result, it's unclear to what extent the reduction in PTSD symptoms are attributable to prolonged exposure therapy versus, say, the pharmacological effects of buprenorphine or methadone. And indeed, there is some interesting preclinical and clinical research to suggest that opioid agonists may have antidepressant and anxiolytic effects. There was a retrospective chart review conducted through the VA among 2,000 veterans that found that buprenorphine was associated with significantly greater reductions in PTSD symptoms compared to SSRIs, which are the first-line pharmacological treatment for PTSD. And then there was also some data that we collected as part of the VCBH group that you can see in this figure here to the right. And in this study, participants were randomized to either receive either buprenorphine alone without counseling, or they continued on wait lists, so they did not receive buprenorphine treatment from us. So you can see on the x-axis, we have time. On the y-axis, we have severity of multiple measures of psychiatric severity. The solid line is those folks who were prescribed buprenorphine, and then the dashed line is those who continued on wait lists. And so you can see that buprenorphine alone, without counseling, was associated with a significant reduction in psychiatric symptoms. We didn't look specifically at PTSD symptoms in this study, and so I'm currently involved in some research. I'm currently conducting a randomized trial in which we're trying to evaluate the effects of prolonged exposure therapy above and beyond opioid agonist treatment for reducing PTSD symptoms among patients with concurrent PTSD and opioid use disorder. And so if y'all ever want to invite me back, I'd be happy to report on the results of that trial when we wrap up here in the next couple of months. And so in conclusion, I've got a couple of minutes left here. I just want to talk about some special consideration for treating individuals in rural settings. So, we've covered a lot of ground today. I feel like I've covered about 5 hours of material in about 40 minutes. But just to add on to that, what we see in rural communities, such as these in Vermont and those in Mississippi that I worked in before coming up here, there are gaps in service provision as well as sociocultural factors that may prevent people in rural settings from engaging in evidence-based treatments for PTSD. And so a lot of this material I'm pulling from an article by Dworkin et al. In 2017. And so I'll talk about gaps in service provision, and then I'll offer some potential solutions. For each of these solutions, these aren't easy fixes, and I don't want to present this as something simple that we can fix, but rather these are some aspirational goals, some areas for future research, as well as some areas for some potential clinical endeavors. So one of the obstacles that we see in rural settings is that PTSD often goes undiagnosed. One solution that I would propose is that I've listed a number of free evidence-based measures of PTSD symptoms, and so implementing these into our clinical practice so that we can identify PTSD in substance use treatment settings and then offer people relevant resources. We also see that in rural settings, there's less access to behavioral health services generally, and evidence-based treatments for PTSD specifically compared to urban areas. And so, I think it's important that we utilize existing community infrastructure, establish collaboration between organizations, and then cross-train treatment providers. I think one great model of this is when I was working at the University of Mississippi Medical Center, our research and clinical training group partnered with several substance use treatment facilities, one in Jackson and one in the Mississippi River Delta. And we delivered evidence-based treatments for several mental health conditions, including PTSD, both in person and via telemed. And this relationship was really mutually beneficial in that we provided we addressed some really clear needs for these substance use treatment centers. We didn't charge for our services, and in return, we obtained some valuable clinical experience as well as research data. So finding ways to partner and utilize treatment structures that are already in place. In terms of sociocultural factors, even though there is no one set of universal rural norms, rural values can include self-reliance or reliance on support networks that either encourage substance use or avoidance of trauma cues. So this can be a barrier to obtaining evidence-based treatment for PTSD. One solution would be to engage these informal support networks in treatment when appropriate, to emphasize autonomy, bringing the patient into treatment decisions, and really framing treatment as a strategy to increase self-reliance. Stigma regarding mental health services is another barrier in rural settings. And one solution that I get really excited about is finding ways to adapt evidence-based treatments that we know work, to reflect local norms, and then to bring in cultural insiders into these treatment efforts. So finding people in the community to get involved, whether in recruitment or treatment or whatever, buying some credibility within these communities. Another obstacle is the disclosure of personal problems to healthcare providers may be discouraged. In small communities, your mental health provider may be your neighbor, your kids, friends, parents, somebody who you come into contact in other settings. And so it's important to emphasize confidentiality, recognize substance use as an attempt to cope, and then really validating that person's desire to recover. And then finally, as we encounter frequently throughout Vermont, is that transportation, childcare, and housing can be barriers. If you don't have transportation, you don't have childcare, making it to therapy sessions can be a real challenge, and probably not real high on your priority list. So again, finding ways to utilize existing infrastructure, meeting people in their community, finding creative funding solutions, and then finding ways to address some of these basic human needs, like whether that's providing in-home treatment, utilizing telemedicine, or maybe even providing childcare as part of treatment. These are all some creative solutions that I think are worthy of additional research to determine whether they improve treatment outcomes. And just to touch on the telemedicine piece, I know that I'm out of time. Telehealth, we've all become really familiar with that in the past year. I think this is a really powerful tool to disseminate evidence-based treatments for PTSD, specifically in rural communities. And there is data that shows that whether you deliver prolonged exposure therapy in person or via telemedicine, it's equally as effective. So thank you for allowing me to go a couple minutes over. I'll just wrap up here. In conclusion, trauma is not an unusual experience. Most people recover with time. But when symptoms don't resolve with time, that breakdown in natural recovery is what we refer to as PTSD, and it's associated with a host of negative consequences. I presented today a number of valid and reliable structured clinical interviews and self-report measures that are publicly available that allow for the diagnosis of PTSD as well as the assessment of PTSD symptom severity. There are effective interventions for PTSD. Exposure-based interventions, I think, hold some distinct advantages in rural populations as well as those with concurrent substance use disorders. But more work is needed to improve the uptake of these assessments and interventions among those with substance use disorders, as well as in rural areas. So thank you for your time. I know that this was a whirlwind presentation. I want to thank my advisors, my research team, as well as funding from NIDA and NIGMS, because without these folks and these organizations, I wouldn't be here today. So thank you so much.
Thank you so much, Dr. Peck, for that super informative presentation. We'd love to open it up for questions and comments. We received a few in the chat, so I'll start there. And then if folks have any other thoughts, you can either put them in the chat or unmute yourself and join the conversation. I'll start. Trish asked how often PTSD is misdiagnosed as general adverse childhood experiences or just generational ongoing trauma.
I don't know what the exact numbers there. I think it does speak to the importance of, doing a careful assessment both of trauma exposure as well as PTSD symptoms, and that, like I talked about, the vast majority of people that we come into contact with in substance use treatment settings have experienced some sort of trauma during their lifetime. And so doing these careful and comprehensive assessments allows us to do differential diagnosis. Are these symptoms attributable to PTSD versus some other condition? And then really allowing us to prioritize what the treatment what are the treatment priorities? So I don't have the exact numbers on that, but I do think that's an important point. And it does speak to the importance of really doing like a careful assessment.
Great. And as we move into the other questions, I'm just going to launch a quick poll here. If everybody wouldn't mind just answering, it's 4 brief questions. We would love your feedback so we can improve these sessions. So Marie said, I was under the impression that Beck's line of inventory screeners was copyrighted and has to be paid to use. Is this correct?
Yeah, that is correct. I listed the Beck measures. So that's a good catch. I did list the Beck measures because they are commonly used in clinical practice. The PHQ-9, so the Patient Health Questionnaire, and then the Generalized Anxiety Disorder 7-item scale, I think are good substitutes that are free, that have some really good data to back them up. And so if you're looking for something that you don't have to pay for, the PHQ and the GAD are the measures that I would go with. The Becks are so identifiable, and some that I use in my research that I listed those. So that's a good catch there.
Great. And then Tim has a question. Can you give an example of adapting evidence-based treatment to local cultural norms?
Boy, yeah, that's a good question. I think given that prolonged exposure therapy is what I do most frequently, I'll use an example there. As you're designing, I talked about the in vivo or the real life exposures that you do as part of prolonged exposure therapy, and that is finding ways to safely and gradually confront things in the environment that remind you of your trauma that you previously avoided. So that could be participation in certain activities, going to certain parts of town, interacting with certain people. And so I think that if we're talking about modifying that to cultural norms, that is like, rather than laying things out and saying, this is what we need to do, is it often involves bringing the patient into that conversation and saying, like, what are the parts of, what types of avoidance are impacting your life the most? And how can we creatively go about addressing those? And then also being sensitive to like some of these issues that I talked about, and that when you're living in a small community, being engaged in mental health care, there can be some stigma associated with that. You might not want other people to know what's going on. And so being sensitive to those issues and designing those exposures in a way that works for that individual and the community that they live in. There isn't like a one size fits all treatment approach, but just kind of being aware, collecting information about where that person lives, their values, the community that they're in, and then trying to design those exposures to fit that person specifically. And so, I think that there are probably 1,000 different answers depending on the community that you're working in, but just being sensitive to those issues and, establishing a collaborative relationship with your patient so that you can make treatment work for them rather than kind of taking a one size fits all approach.
Great. I think we probably have time for one more question, and this also comes from Marie. Is the PTSD 5 valuable?
The PTSD 5. I don't think I know what that's referencing exactly.
Maybe
so I don't.
DSM-5 maybe that you referred to, the manual.
That would make sense.
Yeah, DSM-5.
Okay.
Yeah.
Okay. That's a bit of a loaded question. Like, I talked about if the DSM diagnosis for PTSD, as I mentioned, it allows for a great deal of heterogeneity in terms of diagnosis, and that PTSD, there's over 600,000 different variations of symptoms that could qualify for PTSD. And so it does kind of muddy the waters. I think that, there have been good steps with the DSM-5. I think it's important to have a objectively defined, an objective definition of what PTSD is. I think that we can all quibble and find problems with the way that it's currently defined. I think it's reasonable, but there are certainly flaws with it in ways that we can improve.
Great, thank you, Dr. Peck. And Marie, it looks like we'll follow up with you specifically about your question to make sure it's answered. And unfortunately, we are out of time. So Dr. Peck, I'm going to ask if you wouldn't mind advancing to the next slide. I just want to thank everyone for joining us today. Again, as a reminder, you can claim CE and CME credits using the links we provided in the chat. We will also send that information out via listserv. And then if you go one more slide, Dr. Peck, I just want to highlight our upcoming session with John Brooklyn, which will be happening in February here. And I'll put that registration link there in the chat. And again, thank you all very much for joining us. Dr. Peck, that was a fantastic and extremely informative session. And feel free to reach out if you have any other questions following this session. You can email us at cora@uvm.edu. Thanks, everybody.
Everyone.